Hello, everyone. Welcome. My name is Caitlin Sylvester with the American Cancer Society National Colorectal Cancer Roundtable, and it is my pleasure to welcome you to our Blue Star conversation today. So before we get started, I want to quickly go through a bit of general housekeeping. So the presentation portions of this session will be recorded, and that video recording will be posted to the NCCRT website following today's presentation. We will have Q&A after the panel discussion, so we welcome your questions. You can either enter them via chat or in the Q&A box at the bottom of your screen. And then, just so we can all get to know each other a little bit better, if you all could please put your name, where you're from, and which organization you represent in the chat. And finally, we would greatly appreciate it if you would complete our survey at the end of today's call. So our objectives for today are to provide our NCCRT members with an in-depth, up-to-date, nonpartisan information about the outcome of the Kennedy versus Braidwood Management Supreme Court case. We want you to hear from known experts, and we also want to provide you with a space to learn, discuss, and assess how these decisions may affect your CRC screening-focused work. And then hopefully we'll have time to share top takeaways. I do want to make a quick note that today's conversation has been planned and organized around the Braidwood case and the Supreme Court decision. I know things are rapidly changing, and with the passage of last week's bill, there are a lot of questions about Medicaid and what's going to happen next. We have not had the ability to plan and are unprepared to dive into that conversation today, but I do want to share that ACS CAN is hosting a virtual session tomorrow evening titled Healthcare in Crisis, What Coverage Losses Mean for Cancer Patients in the Road Ahead. We're going to place that information in the chat for you, and I encourage you all to register to attend. You'll hear from ACS CAN President Lisa Lacasse, along with other experts about the impact of the bill and what it'll mean for the fight against cancer. So we just want to be sure that you get the most up-to-date information from the right people. So I thank you for understanding. So before we get started, I'd like to quickly go over some reminders and ground rules. ACS as well as ACS CAN, we are nonprofit, nonpartisan organizations, and we believe that everybody should have a fair and just opportunity to prevent, detect, treat, and survive cancer. We therefore ask that you avoid partisan topics and opinions today. As far as our rules for engagement, we have a set that clarifies the expectations for participation by members and representatives of the roundtable. Members are expected to respect and comply with these rules and all other applicable ACS policies. And you can reference those on our website, and Aubrey will also put those in the chat for you. And I also want to note our panelists are experts in this rapidly changing field, but their opinions are of their own and do not reflect the ACS NCCRT. This panel discussion is being recorded, so please be mindful of our conversation and respectful of others' privacy. Do not identify or discuss any specific patients by name. So if you are new to our Blue Star conversations, we'd like to outline the format to vary from your typical webinar. This series is only open to NCCRT members and is a great way for everyone to not only hear and learn from our expert speakers, but also to engage with our priority team chairs, roundtable volunteers, as well as other attendees outside the annual meeting. Each Blue Star conversation is hosted by one of either our priority teams or another high-level volunteer and features a presentation followed by an interactive session. Today we'll be adapting that to format to include presentations and a panel discussion, and then we'll have our larger Q&A without doing breakouts this time. So I would now like to introduce Dr. Heather Dacus, one of the chairs of our Policy Action Priority Team. So Dr. Dacus joined the New York State Department of Health in 2007 and serves as director of the Bureau of Cancer Prevention and Control to support population and evidence-based initiatives to reduce the burden of cancer across New York State, with a specific focus on cancer prevention, screening, and survivorship. She oversees implementation of several state-funded programs, as well as CDC and prevention grants. Dr. Dacus is a steering committee member of the New York State Cancer Consortium. C5 is a former steering committee member of the NCCRT and now co-chairs our Policy Action Work Group. So Heather, welcome, and I will pass it on to you.
Great. Hi. Hi, Caitlin. Hi, everybody. It's great to be here. Really appreciate it. As Caitlin said, I'm co-chair of the NCCRT's Policy Action Strategic Priority Team. And here on the slide, you can see the charge of that team, and definitely today's topic fits into that really well. My co-chair is Molly McDonnell, and you'll be hearing from her in a little bit. But today we're going to discuss the potential opportunities and challenges that may impact our work from the Kennedy v. Braidwood Management Supreme Court case. We're also really excited to hear your thoughts after we hear from our expert panel. So please be ready to ask questions in the chat so we can ask the experts and have a really good discussion today. Next slide. Briefly, just some disclosures. None of our panelists or speakers have any disclosures to make. Next slide. So I want to go ahead and introduce who you're going to hear from today. Our first speaker is Mary Rouvelas. Mary is Managing Counsel and Legal Advocacy Director at the American Cancer Society Cancer Action Network, which she helped to create back in 2001. Mary, in 2008, founded and still directs ACS CAN's Judicial Advocacy Initiative, which recruits law firms to do pro bono public policy work to serve mission goals. Mary is also a member of the U.S. Supreme Court Bar, the U.S. Courts of Appeals for D.C. and Fourth Circuits, the District of Columbia Bar, and the Virginia Bar. He's worked on numerous amicus briefs filed at the U.S. Supreme Court and the U.S. Circuit Courts of Appeals, as well as being counsel of record for public health organizations at the U.S. Supreme Court in landmark cases of National Federation of Independent Businesses v. Sebelius and King v. Burwell, which upheld the Patient Protection and Affordable Care Act. Mary serves on the Activism Advisory Committee of National Multiple Sclerosis Society. And also on a personal note, she is married and has 2 children, and we'll put her bio in the chat. We're really happy to have Mary. I also want to go ahead and introduce Josh Caplan, who we'll also be hearing from today. Josh is the Director for Government Affairs at Academy Health, where he develops and oversees advocacy and public policy strategy. He is responsible for proposing and implementing Academy Health's legislative policy and regulatory work in support of the continued production and use of robust, rigorous, and timely health services and policy research to improve health and healthcare. In this role, he works closely with our community and membership to ensure that Congress and federal agencies are informed about the importance of health services research and that regulations and strategic plans are developed and implemented in thoughtful and effective ways. We're going to put Josh's bio in the chat as well, so please feel free to take a look at that. And finally, we're going to also hear from our other co-chair for this policy strategic team, and that is our very own Molly McDonnell, Vice President of Advocacy at FIGHT CRC. Molly joined FIGHT CRC in 2019, and prior to coming on full-time, she was a principal at the government relations firm Winning Strategies Washington, where she worked with clients from across the healthcare sector to creatively tackle their most pressing policy and advocacy challenges. Having lost her great aunt to colorectal cancer, FIGHT CRC's mission has always been close to her heart. Molly spent 5.5 years working on Capitol Hill for Congressman Leonard Lance of New Jersey. He served as Congressman Lance's senior health policy advisor, working on issues related to medical research, public health, drug development, and health coverage. So we have a great panel. You can hear and know that they are clearly well placed to have this conversation with us. So first up, we're going to hear from Mary. Mary, go ahead.
Thanks so much. Really appreciate it. And I apologize, my voice is a little raspy because I'm getting over a respiratory illness, but I'm delighted to be with you today. And I'm going to basically give you the quick and dirty on this case as it has, gosh, I'm giving you about 7 minutes over the last 5 years or so. So it's going to be very high level. And I will go over the recent conclusion with the Supreme Court, but I will also say it's not the end of the case. It's going to keep going on for a while. And I'll explain that too. So we have been very focused on this case at the American Cancer Society Cancer Action Network because it had such huge implications for cancer prevention and early detection, major priority for us. So next slide. First, I'm going to outline for you the provision of the Affordable Care Act that makes this so critical for our mission. The Affordable Care Act has a provision that says that most private insurers must cover preventive services without cost sharing if they are recommended by the 3 entities that follow: the U.S. Preventative Services Task Force. Oops, yeah, okay. The Advisory Committee on Immunization Practices, ACIP, which has been in the news very much lately, and the Health Resources and Services Administration, or HRSA, on recommendations about women's preventative health service. These recommendations cover about 150 million people. I'm sorry, the insurer provisions, and it includes the Medicaid expansion population. So this mandate about coverage of services without cost sharing affects about 150 million people. So absolutely huge range. And this is part of why we're so focused on it. Next slide. And as you all know, of course, the part of the things that are covered are the colorectal screening, breast cancer screening, lung cancer screening. All those fall under the U.S. Preventative Services Task Force recommendations. So what is this lawsuit about? The plaintiffs in the lawsuit are individuals and Christian-owned businesses. And there were, at the beginning of the lawsuit, there were two sort of primary claims that I'm going to explain to you. One is that the requirement, the first argument was a constitutional one, saying that the U.S. Constitution requires that superior officers of the United States must be appointed by the president and confirmed by the Senate. And inferior officers do not need that. You're all familiar with this process without knowing probably where exactly it came from in the Constitution, because officers like the Secretary of Health and Human Services, there's always a very widespread media around that process of them being appointed by the president and confirmed by the Senate. And that becomes crucial to this case, understanding that it is a constitutional argument here. The other main argument that they brought in front of the court at the district court phase was under the Religious Freedom Restoration Act, which we affectionately call RFRA in the legal field. And they were saying that the requirement violates their religious freedom because they have to buy coverage that they don't believe is moral. So the original claim also said that would cover PrEP. They did not want to have the task force essentially recommendation that men who are gay and engaged in sexual conduct should be on PrEP as a prophylactic preventive measure, that would have to be covered. So they did not want to have to cover that according to their religious beliefs. Next slide. So why do public health organizations care about this case? Well, and I alluded to this before, task force recommendations include lung cancer screening, breast cancer screening, tobacco cessation, colon cancer screening, and cervical cancer screening. So you can imagine this is really such an enormous thing in terms of cancer prevention. The other thing we know is that even a modest copay of $5 or $10 on these services means a lot of people will not get them. And the ones who are not going to get them are usually among populations that already suffer from health disparities. So that it would exacerbate health disparities if these services are at risk. The other services or the other entities were ACIP, the vaccine entity, and HRSA for behavioral health. Next slide. So what happened at the district court? Judge Reed O'Connor, who is pretty much a hater of the Affordable Care Act in general, based on a number of rulings he's had in his courtroom, he ruled in this case that the Affordable Care Act's delegation to the task court violates the appointments clause of the Constitution. So therefore, it was unconstitutional. And his original ruling said that no recommendation since the passage of the Affordable Care Act in March of 2010 could be enforceable by HHS for the entire nation. So essentially, he was saying the HHS could not go after insurance companies for not providing coverage without cost sharing, if that makes sense. However, at that same time, he upheld the delegation of the authority to ACIP and HRSA because their recommendations have to be ratified by the HHS secretary. So under his original ruling, the task force was unconstitutional, but ACIP and HRSA, because there were other procedures in place that they had to basically go back up through the secretary and could be vetoed by the secretary, those did pass constitutional muster. He also ruled that the requirement to cover PrEP violates Braidwood's religious freedom under RFRA. And he went further to say it would also apply to the HPV vaccine. So you can imagine how we felt about that. But then this claim actually dropped out of the lawsuit, because what happened was when it was time to appeal it, the government said, well, as long as this ruling on RFRA only applies to the plaintiffs, we will not appeal it. So essentially that issue, which got a lot of actual media coverage during the time, drops out of this case. So now what we're left with is the task force, ACIP and HRSA. Next slide. So what then? This is a map that I like to show folks who haven't gone to law school. I had no familiarity with it before I went to law school. This is the circuit courts of appeals. So you'll hear people say, oh, the Ninth Circuit, the 10th Circuit, 6th, 7th, whatever. This is your map. And the reason I like to put it in here is just to sort of ground you in where we are. Texas is in the 5th Circuit, which is basically now sort of considered to be the most conservative circuit. And so a lot of challenges to, what conservatives would be considering liberal policies are brought in the 5th Circuit. The other fun fact that I'll leave you with is the reason they're called circuits is because actually way back when they were established, the judges actually used to have to ride in a circuit on horseback in these jurisdictions. So that's why they're called circuits, because they would have to ride in a circuit. Back then, it was actually not so desirable to be a judge that had to ride in the circuits, because it was physically grueling and you had to, be away from your family for months at a time. But things have changed. So, but this is the map. I just wanted you all to understand where we are procedurally. We're now in the 5th Circuit. Next slide. So at the 5th Circuit, fortunately, and a number of our public health groups, including ACS CAN, urged the 5th Circuit to stay the district court's ruling during the rest of the litigation. So although Reed O'Connor had found that the task force recommendations were unconstitutional, that they essentially put his ruling on hold to make sure that services were not interrupted. And they did do that. There was a whole sort of back and forth, but they did do that. So that was actually a big victory in and of itself. The other thing that happened when the 5th Circuit made its ruling was that they ruled that the task force was unconstitutional because of how it was structured, but they also limited the relief to the plaintiffs. So you went from having about 150 million people potentially affected to having not even a couple hundred people affected. So that in and of itself also seemed like a victory at the time. On the other hand, it sort of left lingering issues of whether other people could challenge it and that sort of thing. And then ACIP and HRSA, they ruled that yes, those were constitutional, the way that they were structured, that Reed O'Connor had gotten that right. But they also went further to say that it needed to be done procedurally in a certain way, that the secretary had the ability to ratify those recommendations, and whether or not that had been done properly from a procedural standpoint was yet to be determined. So they actually remanded those issues back down to Reed O'Connor to say, you, Judge O'Connor, have to figure out whether the right process was observed during this time. Okay, so next slide. So as you can imagine, with a case like this, everybody decides to petition the Supreme Court to hear all the issues. So ACIP, HRSA, task force are all put in front of the Supreme Court. Well, part of the reason it would be so great to be a Supreme Court justice is because they get to pick what they decide. So they get to decide whether or not they're going to take a case. And in this instance, they decided that they wanted to take the appeal on the task force, but that they were not going to hear the appeal on ACIP and HRSA, which actually from the public health standpoint, at least where we were sitting, that was a victory, because remember that the task force was the one that essentially government had lost its argument on, that it was found unconstitutional. So next slide. So they, like I said, they only accepted the question of the task force. And then, and this was the big news, a week and a half ago, what they did was they held the structure of the task force does not violate the appointments clause of the US Constitution, because the members are inferior officers under the supervision of the Secretary of Health and Human Services. So that was sort of, you had to accept that argument that they were inferior officers under the supervision of the secretary. in order to win the constitutional case, but then it poses other issues, which I know some of the rest of the panel will get into. And then they upheld the provision that mandated coverage of the task force recommendations. So overall, this was actually quite a big victory from our standpoint at ACS CAN. This is what we've been advocating for years. But it also created, a number of questions that I think we're going to get into. So with all that being said, I want to say, please, if you have questions, put them in the chat because we're going to do Q&A later. But that is the big picture on this case that was just decided. So, and now I'm going to hand it off to Josh.
Thanks, Mary. That was a great description of everything that has been going on. So I'm going to try to keep my remarks a little bit shorter about like the what's next. So I'm Josh Caplan. I'm the Director of Advocacy at Academy Health, which is the professional home for health services research. We are also the lead for the Friends for the Agency for Healthcare Research and Quality, AHRQ ARC. ARC is the federal agency that has a statutory mandate to do health services research and healthcare delivery research, and it's also where the task force is located. Academy Health has been engaged in this case, also since the district level, writing briefs about the importance of the impartial and evidence-based expertise that the task force has for the healthcare system. Because as we've already discussed so far, the task force is critical for identifying what preventative care should be delivered at no cost to over 150 million insured Americans, but it also provides credible information for practitioners and clinicians inside the exam room. So it's something that it has these policymaking implications, but it also is a trusted messenger for being able to understand the plethora of information that we are all receiving to be able to see what actually helps with preventative care. As Mary mentioned, the task force isn't the only aspect that feeds into the no-cost coverage. There's also the Advisory Committee on Immunization Practices, ACIP, as well as the Health Resources and Services Administration, HRSA. And I think Mary did a great job explaining which ones are doing what. The reason why I'm bringing that up is to put the word ACIP into your mind, which we're going to get to in just a moment. So as Mary pointed out, the lawsuit was actually a bit of a mixed bag, even though it was the result that we wanted and it was correctly found. Because what the court had found was that the Secretary of HHS has the power to appoint and has appointed the task force members, and that there is no statutory barrier to them removing the task force members, i.e. the Secretary can appoint or remove anybody on the task force. And this is where the ACIP concerns come in again. So the task force is a potential source for Secretary Kennedy to pull an ACIP, which I have now used that as a bit of a noun, I suppose, of purging the advisory council of the experts who are on it and who've been on it for years in order to place people who are more ideologically driven or less likely to be engaged in rigorous engagement of the evidence. And that's something that we're deeply concerned about. With ACIP, they purged the 15 members and put in 8 new members onto ACIP. And these new members are people who are disproportionately skeptical about the consensus science on vaccines. And they now have the ability to be able to change the way that these vaccines are administered or covered by insurance companies. And something to keep in mind is that the initial impetus for the Braidwood case was to eliminate access to PrEP by eliminating the task force itself. So a possible next step that we have to be aware of is Secretary Kennedy eliminating the people who are on the task force, putting people on who will then use less than credible evidence to push PrEP out of coverage or other types of cancer screenings. It's one of our biggest concerns, to be honest, because there's very little legal recourse we would have after the task force makes its recommendations. So one of our big concerns right now then is having the ACIP experience with the task force. And in fact, we have reason to think that this is very likely to happen. Just this morning, a previously scheduled meeting for tomorrow was abruptly canceled, which is a blaring alarm about the risks and dangers that the task force is under. Furthermore, before the Braidwood case was even decided, the president's budget request for FY26 calls for a 40% cut to the task force. Now, the president's budget request is just that, it's a request. And historically, it's always been something that is then considered by Congress and a actual appropriations is passed. But as we've seen over the course of this calendar year, the administration is more than interested and willing to impound funds, i.e. not spend funds that Congress has already appropriated. So it is possible that 40% is a higher risk likelihood than it otherwise would be in any previous administration. So talking a little bit about what we can be doing next. First and foremost, the Friends of ARC is circulating a letter to Congress to protect the task force with a focus on the importance of protecting the integrity of the process that people on the task force have been put in or removed to be able to prevent that ACIP situation from happening. As I had mentioned, the alarm bells are ringing. So this letter was originally going to be open until close of business this Friday. It's now going to be open until just 3 p.m. today, and it's going to get put into the chat in just a moment. This is an organizational sign-on. So if you are in a position where you can have your organization sign on between now and 3 p.m. Eastern, we'd be grateful for your support. There's already 100 organizations that have signed on to it, and I'm happy talking more about that. The next thing is closely monitoring what the task force will be producing over the coming months and years if this purge goes through. The people who are on this call are all experts, and we're asking that you use your expertise as a warning system. Let us know what you're seeing that is causing concern so that we can then amplify it at Academy Health and the Friends of ARC. The third thing you can be doing is just monitoring the news and just following what's happening in the task force and also HHS more generally. At Academy Health, we've started producing what we call the Situation Report. It's a newsletter we put out twice a week about the federal policy implications that we are concerned about or we think you should know about. It's on the outside of our paywall. You can follow us on LinkedIn. We put it out twice a week. If you're a member of Academy Health, you probably see it in your inbox. And then finally, we ask that you call on your professional societies, your health systems, your universities, and more to be proactive and fearless fighters for better evidence in the policymaking system. We simply cannot be sitting out any of these fights that are happening around us. The more we are engaging with the evidence and the value of good evidence in having good health outcomes, the better off not just our patients, but our health systems are going to be. And what we really need as professional societies is to hear from our members that they want us working. It gives us a lot of credibility in those conversations. With that, I'm so excited to be able to turn it over to Molly for her thoughts. Molly?
Great. Thanks, Josh. And thanks, Mary, for that great overview of this case. So I just wanted to provide a little bit of background on sort of the colorectal cancer specific advocacy perspective around this. I think Josh and Friends of ARC and ACS CAN and many others have done a great job around this case that's obviously impacts far beyond just the colorectal cancer space. But as this case moved its way through the judicial process, Fight CRC felt, one, that it was really important to raise the alarm around the potential impacts of this case, but also to bring the colorectal cancer community together to have, kind of a united front and united response to this case. So earlier this year, we brought together what we're affectionately calling the Colorectal Cancer Screening Work Group, which included advocacy organizations, physician partners, and industry partners as well across the colorectal cancer space to really come together and think about how we wanted to respond to the potential outcomes to Braidwood, and now that we have an outcome, potential further threats to the task force and ultimately to access to colorectal cancer screening. So through that working group, we really started with just pulling together information, data, resources to make the case around the value of colorectal cancer screening. So there's so much great data out there. Obviously, we've seen the importance and the value both from a patient health perspective, but also from an economic perspective as it of colorectal cancer screening. And so we wanted to make sure that we kind of brought that together in one place so that we had kind of a common set of talking points and resources that we could draw on should we have to go to Capitol Hill, go to the administration, speak to the media, whatever it may be, to raise awareness about this case and the subsequent challenges. So we put together a 2-pager that includes those resources that I was actually negligent in sending to Aubrey before, but I'll send along, so happy to share with this group. But we felt it was a great way to make sure that, if we are having these conversations across the colorectal cancer community, that we're singing from the same song sheet and not giving, whether it's an administration official or a staffer on Capitol Hill, any reason to kind of dismiss what we're saying or, say, hey, like, we don't want to touch this because 2 different groups are saying 2 different things. So I think it's a great resource to pull from as well, to help educate your community, whether you are a patient advocacy organization, serving the patient, survivor, and caregiver community, whether you work for a health system. It's just a great way to kind of get folks up to speed on what's happening and certainly reiterate the importance and the value of colorectal cancer screening. So in addition to that, we also put out a pair of joint statements with the group, both when oral arguments began in the case and then once we had the results, again, to show a united front across the colorectal cancer community. And I think Aubrey has already put that in the chat. So just another opportunity for us to help raise awareness about this and show, the community's commitment to access to no-cost colorectal cancer screening. And so, going forward, I think Josh offered a lot of great examples of, ways that we can kind of continue to be engaged around this. Obviously, we remain, while we view the outcome of the case as a victory, we remain concerned about Kennedy's potential impact on the task force and what that might look like going forward. So we will continue to closely monitor any, proposed or real changes to the task force. And both as Fight CRC, we're happy to continue to put that out into the community. But my other hat, as Heather mentioned at the beginning, is I am also a co-chair of the NCCRT's policy strategic priority team. So within that, we really view ourselves as a way to help share information about what's happening, share opportunities to get involved. NCCRT, is obviously nonpartisan, as is Fight CRC, but they don't directly lobby or advocate. So we really see the strategic priority team as a place to share and exchange information on these topics. So we want to continue to be a resource to this community on things that are happening around this case. And I'll also just add that putting my Fight CRC hat back on, we're also, ensuring that we continue to work with groups like Josh's, Friends of ARC, like ACS CAN, groups like United States of Care, groups that are also really engaged around this case and potential actions on the task force. Like we've said, the task force expands far beyond colorectal cancer and far beyond just cancer screening. So we are, making sure that we're staying aligned with our partners across the healthcare space. Again, to make sure that we are presenting a united front and we're able to, kind of lock arms across the community to combat anything that should come up around this issue. And so we like I said, we'll continue to monitor. I'll add our resources in the chat. Of course, if you want to get in touch with me, happy to share my email as well. But appreciate the opportunity to chat with you today, and appreciate NCCRT for hosting this this discussion. I think when we originally sort of organized this call, we didn't know just how timely it would be, but I think even though the sort of court case is behind us, as Mary and Josh explained, there's still definite risk and much more work to do ahead. So look forward to working with folks on this call and beyond to continue the great work that we've done in the colorectal cancer space. So I will pause there and turn it back over to Heather, and I think we'll take some questions.
Great. Thank you, Molly. Thank you, Mary. And thank you, Josh. Really timely and clear updates for us all to hear. We would love for everybody now to start putting your questions into the chat so we can get to your questions in a few moments. We're going to bring all the panelists back up on the screen along with me and just go over a couple of questions that we've written down. So one question that I have, so the audience for this conversation is those who work in public health, those who are clinicians, people that work within community-based organizations. So you sort of each touched upon this, especially Josh and Molly, but I'm wondering if each of you could just briefly say, what do you think is the best way for everyone on the call to stay informed about what's going on? Josh, do you want to take that one first?
Sure. So I encourage you to follow any number of larger newsletters that are going out. I know American Cancer Society is phenomenal for highlighting challenges coming down the pike. I mentioned at Academy Health, we have our situation report, which you can follow either as a member of Academy Health or by following us on like LinkedIn or Blue Sky. Every morning I read the Politico Health Pulse. I read the Washington Post Health newsletter, the 202. These are all great opportunities to be able to just kind of see the conversations that are happening. And as a former congressional staffer, I spent 7 years on the Hill. One thing that frustrated me the most was I never heard from experts. They never really saw me as a dissemination audience for the work that they were doing. And I would always say, I'm flooded with meetings, and if experts aren't talking to me, who is? And what are the implications of that on policymaking? So I encourage you as experts to be engaging with policymakers around you, to let them know what's happening on the ground that you're seeing. Like, what are your needs? We need to be loud to be able to break through a lot of the misinformation that's existing in our ecosystem right now.
Yeah, that's a great way to put it, Josh. Thank you. Mary, anything that you want to add to that? Places people can be tracking the information?
I mean, the only thing I would add, I think Josh said it all super well. From the court end of it, this case is going to continue on ACIP and HRSA at the district court, so it's not over yet. I think for this audience, which is focused on colorectal, it is pretty much over because the task force piece is over from a legal standpoint. So it really is on the implementation, but just so that other folks are aware, to the extent you have broader interest in colorectal, we plan to remain engaged in the case because ACIP and HRSA are still on the chopping block, essentially, at the district court.
Thanks, Mary.
And I would just echo what Josh offered in terms of the importance of engaging in elected officials. I know that can sometimes be an intimidating thing. Sometimes, depending on where you work, there may be limitations on your ability to do that type of engagement. But I would say, I would offer myself and Fight CRC as a resource. We are happy to be a conduit of that information. If you feel like you aren't able to, reach out to members of Congress directly, we're happy to help with making those connections or, the best way to do those things. But I think there is, you know, definitely a huge need and vacuum of that type of expertise right now on the Hill and within the administration. And so the more that we can put forward what is, you know, the work that we've done, the research that we've done, I think it's just incredibly important. And in one of our conversations within our screening working group, you know, we sort of pondered the possibility of colorectal cancer screening becoming a political issue, which, you know, we you know, kind of dismissed in the moment, but I think, you know, 10, 15 years ago, vaccines were not seen as a political issue. And today we're facing a much different landscape. So I don't, you know, I don't say that to be alarmist. And, you know, I certainly hope that colorectal cancer would not become politicized. But I think we are in a time when we can't afford to, you know, sort of sit back and hope for the best. And so we, you know, we have the data, we have the information, we have the evidence to show its effectiveness. And the more that we can put that into the public sphere, the better.
That's great. We already have some good questions coming in, but I want to just ask two more of the group while more questions come into the chat. You know, my whole career, I've relied on the task force recommendations, whether it was clinically or then in public health, working in a state health department. So they're really important, but they cover a lot of different topics, right? As we're talking about, it's not like vaccines, which is the focus of ACIP. This is the gamut of preventive care. So I'm wondering if anybody, given the concerns that you're all talking about, you know, are there individual ones that we see as being at risk of sort of being changed as far as a recommendation, or is it more, in your opinion, the global work of the task force that's at risk? I don't know, anybody who would like to take that question.
I might take the first swing. So the task force has put out over 300 recommendations over the course of its existence. It's a lot of recommendations, and I'm sure that there's going to be organizations that are sifting through each of them to see which ones are at the most risk. At Academy Health, we're focused more on the larger ecosystem, though, and especially the concerns moving forward. I had mentioned in my opening remarks that it's entirely plausible for the task force to take out PrEP, for example, through changes in the recommendations that are not necessarily based on any new evidence, but rather on ideological priorities. I think the same concerns are around a number of cancer screenings. I would be very concerned, especially with some of the politicization around like HPV vaccines. And there's a lot of worrisome rhetoric that I think is existing in the same area that new task force members might be drawn from. So I'm deeply concerned about what's coming. And I think we all should be.
And I would just add to that, I think certainly there are certain recommendations that maybe will have a bigger spotlight or potential target on them. But also, as Josh mentioned earlier, there's the funding component of the task force as well. So even prior to the Supreme Court case or the Braidwood case broadly, you know, there was, I think, healthy criticism of the task force in the timelines of review. And, you know, a lot of that was around a lack of resources. You know, the budget of the task force is fairly small. And so to see even further cuts to the task force budget is also kind of a sort of a backdoor way to further sort of erode the capabilities of the task force. So I think that's something that we'll be watching closely as well. And I know Josh as well.
Yeah, because I mean, to just put a sharper point on that, because I couldn't agree more. The Agency for Healthcare Research and Quality has been devastated by the rifts and the reorganization, none of which are bound by law. Approximately of the people who worked at ARC, for example, on January 19th, 80% have been fired already. Like 80%. The extramural grant program has been functionally zeroed out. They're coming for this funding on the task force. And these organizations are already way too small for the tasks they have in front of them. I mean, the task force itself is trying to clear a beach of sand with a spoon. and we just keep cutting it and cutting at it. So it's a huge concern. And I appreciate Molly bringing that up.
Right. Thank you. I want to jump over to one of the questions that's in the chat, which is sort of tied to what we're talking about. So the question is, Secretary of Health and Human Services may have the capacity to ratify individual decisions, recommendations made by the task force from 2010, start of the Affordable Care Act, up to 2023, which was the start of the Secretary ratifying task force members, opposed to the AHRQ director, who is an inferior officer. Do you envision this as a real possibility? A little more specific.
I guess I want to clarify the question a little bit, if we can. Is it about who is going to be appointing the task force from here on out, or I'm not 100% clear on the question.
The question relates to the explicit ability of the secretary to go back to prior USPSDF recommendations from the specific time period and potentially at line by line say yes or no to various recommendations that have been made. And given that there may be this opportunity, do you envision this as a real threat?
I do envision it as a real threat. And just to kind of back out and say, one of the things that Becerra did, because obviously Secretary Becerra was in before Secretary Kennedy, did in order to try and sort of make the constitutional question go away, was to ratify individual recommendations by the task force to help with the argument that essentially they had to go through the Secretary of Health and Human Services. That would aid the argument that this was constitutional if he had ratified them. And it is definitely within the Secretary's power to rescind those ratifications. And that is something that, we have been kind of futuring on, at ACS CAN, that is something that could be out there. And, had the case gone differently, you could have also basically done something like do an emergency petition to try and get a rulemaking set so that HHS would have to go through an official process for this. Now, that's not going to be necessary as a result of the Supreme Court case, but we're still going to be paying attention to those individual recommendations, because I agree, Andy, the individual recommendations are each at risk. I hope that answers your question.
Yes, thank you.
Another question that comes to mind is, how do we message what's going on to people that aren't, for example, on this call? Those of us who are pretty familiar with the topic areas and the players, et cetera. When you think about a lot of us working directly with, whether it's individual patients or people in the community or just other entities, what's your advice on how to talk about this case and the risks to the general public, if you will?
One thing that we had really sort of debated early on, because ACS CAN started engaging in this case over 2.5 years ago, was the fine balance between not creating a general panic that people thought their services were not going to be covered, and yet creating awareness of sort of the threat that's out there. And I think at this point, what we're doing is always going back to our North Star of evidence base, and the messaging to be consistent that what these entities need to be doing has to be based in science. We care deeply about the science, science saves lives, that sort of thing. Because again, it's always going to come down for us to the evidence base. And so to me, and Josh basically said this already, but your messaging needs to be, make sure that science is dictating the coverage.
Fully agree. And I think this is certainly a much larger statement than we have time for the next 10 minutes. But one of the biggest crises we're facing right now is just rampant distrust in expertise and in science. And in some ways, not all, but some, that's a communications challenge that we have. We as a large sector of folks just haven't been communicating the importance of evidence and the importance of the scientific process, the messiness of all of it. in a way that has resonated with a large segment of the population. And that has allowed a lot of unscientific and general animosity to really fester. So the importance of communicating what the task force is, the importance of these recommendations, how any patient can go onto the task force's website and see all of the documentation and understand it. Like, I think this is a really important thing that we all need to be doing. And that is both an organizational and an individual charge for all of us.
And I think from a colorectal cancer specific perspective, I think there's two things. One, just sort of creating greater awareness as to what the task force currently covers, but also understanding that coverage for colorectal cancer screening predates the ACA connection to the task force. So what's important with that is that, one, there's this history of coverage for colorectal cancer screening and the importance of that. But we have built on that through the task force and through the Affordable Care Act with lowering the screening age to 45, some of the newer non-invasive screening modalities, also ensuring that the follow-up colonoscopy is covered after an abnormal non-invasive. So I think that's for a lot of sort of the general public, the connection is not always made between, why those things are covered, but also perhaps from a public health standpoint too. We, recommend or prescribe these things to our patients, but may not always have the awareness of, why they're able to get it at no cost. So I think that, opportunities like this and venues like NCCRT are a great way to help inform the community. But I also think, to Josh and Mary's point, there's a much sort of broader conversation that needs to happen around this, and that delicate balance exists between not raising the alarm to sort of a level 10, but also helping folks understand that there are risks to sort of the status quo.
Thank you. I think we have time for maybe one last question, like 2 minutes for one last question. Any thoughts about approach as it relates to monitoring things at the federal level, taking action at the federal level versus things that could be happening at the state level? Any insight into those two perspectives?
I'm happy to jump in on this one. I think from a state perspective, as Braidwood sort of winded its way through the judicial process, we did see some states start to take steps to codify the coverage for colorectal cancer screening within the task force, within their state statute. I think there's no harm in continuing to do that in other states. And from a federal perspective, I think what we mentioned before in terms of funding for ARC is sort of the most natural place of engagement, but also, to continuously engage with our members of Congress to help them understand that if changes are happening, via the administration, what the impact of those changes are. So a lot of what we have put together in our screening resource is not just the progress that we've made to date, but what could be accomplished if we continue that coverage, and what is at risk if that coverage goes away. So I think those conversations with elected officials are really important. And while, certainly Secretary Kennedy has discretion over the task force, there is also oversight authority among Congress that we should be pushing our elected officials to utilize.
Great. Thanks, Molly. I do see in chat, I know we don't have time to get to it, but Gregory Cantor asked a question related to the fact that there are, other national guideline bodies. So if anybody would love to respond to that question in the chat, please feel free to do so. But I want to turn things back. First of all, I want to thank Mary and Molly and Josh for your time and your expertise. This has been incredibly informative. Still a lot for us to do, but I want to turn it over now to Caitlin to close this out.
Hi, everyone. Thank you so much, Heather. And again, a huge round of applause to our wonderful panelists. They are so generous with their time and their expertise, and I'm so thankful that we could have you all on today. So I think, when we kind of summarize, a couple of the key takeaways are stay informed, stay connected, talk to and hear from, experts, share your experiences, and connect with others in the colorectal cancer community. Things can be overwhelming. It's easy to kind of take a step back, but I think ensuring that we're all able to communicate with one another is huge. And just as a reminder, advocacy happens on a local level, a state level, a national level, and you can kind of get in where you fit in. But sharing your stories with your elected officials can have an incredible impact. And then communicate with your partners, your colleagues, your friends, your family. Let people know what's going on and the potential implications of these outcomes. So just as a reminder, I encourage you all to go to fightcancer.org to learn more about ACS CAN's work in this area, as well as you can sign up for their virtual session on Medicaid, which will be happening tomorrow. We'll also be having our annual meeting upcoming in November, where we're going to have our policy team get together again. It's always a really wonderful conversation. And of course, please don't forget to take our evaluation. We're always trying to improve, and your feedback is really important to us. You can connect with us on LinkedIn. We are on X, and then of course our website. So again, thank you all. We appreciate you so much, and we look forward to seeing you all again soon. Thanks.